All right, so good morning, everybody. Happy Friday. Thanks for joining this week's AMSSM Sports Ultrasound case series. A little different today. So our presenter today is Scott Klaas. He's the current sports fellow out at Columbia Cornell out in New York. He got a last minute call, has a trip, which I think he'll explain in his video, overseas with our U.S. soccer Paralympic team for a match over there. So he is not presenting live. I do think that he is going to try to hop on via phone to answer questions at the end, hopefully. If not, as usual, I'll make a couple comments. I don't know if Doug's coming on today, but if so, he will as well, and we'll open it up for questions. Otherwise, we'll get rolling here. I'll start this video. If for whatever reason you guys can't hear the video, somebody just unmute themselves and yell at me. Let's see if this works.
Hello, everyone, and good morning. My name is Scott Klaas. So to begin, I wanted to start with some thank yous. First of all, my program director, Dr. Chris Visco, who has taught me a lot about ultrasound and was the attending on this case. And I just wanted to say thank you so much for that, as well as the rest of the staff at New York Presbyterian, who's been great at forwarding my education this year. The organizers, Dr. Cruz, Dr. Hall, and Dr. Hoffman, for putting together an awesome series, and everybody else for presenting and contributing to these great videos. And thanks for putting it up on YouTube as well, so I can watch them over and over. So the learning objectives. Number one, we want to understand the protocol for sonographic evaluation of the fibular nerve. Second, we're going to apply this protocol to the case. And third, we're going to learn how to write a comprehensive report. So let's talk about the case. The case is of a 59-year-old male. He had a substance use disorder, currently alcohol and tobacco, but in the past he had cocaine and cannabis as well. The chief complaint when he came in was 3 months of left foot drop with decreased sensation and anterolateral leg and foot. The inciting event started in September of 2021 when he had a buttocks injection of naltrexone for his alcohol use disorder. He said that he was stuck 3 times and he had soreness for around 7 days afterwards, but eventually that resolved. 3 weeks later, he was sitting for around 3 hours while studying in a library, and then he noticed pins and needles in his left lower leg. 2 days after that, he developed some foot drop. Previously, this gentleman was jogging 4 to 5 miles per day, and currently he was only able to walk 6 blocks. You can see over in the picture here, obviously when they do these injections, it should be in the upper outer quadrant, but he said that he felt like it may have been somewhere else. So physical examination, on inspection, there was no atrophy, no tenderness to palpation. He had decreased strength in ankle dorsiflexion, eversion, and great toe extension, as you can see there, and a little bit of decrease as well in ankle inversion at 4 out of 5. He had full hamstring and plantar flexion strength. As well, with his sensation, it was decrease in the anterolateral leg, the dorsal foot, and the web space between his first and second toes. Upon special testing, he had a negative Tinel sign at the fibular head. So prior workup, this gentleman first presented to the ED when he had that foot drop. They did an ultrasound scan and ruled out a DVT. They then consulted neurology, who ran a battery of labs, including an anti-GM1, which was positive. Otherwise, the rest of the labs were negative. He also had an MRI of the lumbar spine, which showed some degenerative changes. And he had an EMG nerve conduction study, which was positive for sciatic neuropathy versus lumbar plexopathy. There was a working diagnosis of common fibular nerve injury versus sciatic neuropathy. On the differential, they also added multifocal motor neuropathy due to that anti-GM1 being positive, but felt that was less likely as only the fibular nerve was involved. The neurology team then consulted neurosurgery, thinking there might be a release they could do at the fibular head or somewhere else. And neurosurgery ordered an MR neurogram and then referred to us to do an ultrasound of the fibular nerve. So what's the scanning protocol? First, on the left-hand side, you can see the essential nerve. So this is the meat of the study. We want to look at the sciatic nerve, the entire nerve, but specifically what we can see starting out at the greater sciatic foramen where it enters. look at the piriformis where it can get entrapped. Then we'll also look at the common fibular nerve. Specifically, we want to look at the biceps femoris tendon and the fibular head and tunnel, which are two common areas of entrapment. We want to look at the deep fibular nerve, and we're going to scan that from the anterior ankle all the way up or down from the split where the common fibular nerve turns to deep fibular. We're also going to go at that same split down the superficial fibular nerve, at least to where it exits from the fascia. The articular branch of the fibular nerve, the third split, we'll scan to the tibiofibular joint. We'll also look at the lateral cerulocutaneous nerve. And then as we're doing the scans, we'll also be noting some of the soft tissue, including the hamstrings, the biceps femoris short head, as that is innervated by the common fibular nerve, and the anterior, lateral, and posterior compartments of the leg as well. These are the additional structures that you can do if there's a more specific area that might need to be scanned. We've seen quite a lot of cases over the year, and often people have surgery and there may be one of the smaller branches being affected after, say, ankle surgery or other issues like that. So as you can see, those are the superficial and deep fibular nerve smaller branches as it gets more defined. Underneath that, we also would look at the medial cerulocutaneous nerve and sural nerve, as there can be abnormalities between the different ways in which the nerves form, and they can present very similar to lateral leg sensory changes. So that's important if that's your only diagnostic finding that you see on the clinical exam. And then the posterior compartment of the leg as well. So scanning protocol, the considerations we'll make first with the transducer. We used mostly an 8 to 18 megahertz hockey stick in this situation because it gave us higher frequency as the fibular nerve is quite superficial. When we look at some of the scan for the sciatic nerve, we also use a 3 to 12 megahertz linear transducer. With a larger patient, you may need a curvilinear as well, depending on the body habitus. As far as the patient positioning, there's two options, prone or sideline. Prone is nice because it allows you to make side-to-side comparisons, so you can look at the left and right very easily. If you're side-lying, though, it can also be helpful when you're looking at that distal aspect of the deep fibular nerve, which is really more anterior. And also sometimes the patient will have difficulty where you can't get to the head of the fibula because they're lying with a bit of internal rotation of the hips. Generally in the scan, we start with the short axis, and then we'll go to the long axis as needed. And I'll explain how we do the scans once we get into it. So some anatomy review, first reviewing the sciatic nerve and the locations we talked about. So the first part here, we're gonna notice the nerve as it comes out of this area, which is the greater sciatic foramen. We'll see the piriformis, and it'll be in the relationship of the sciatic nerve, whether it's through deep to or superficial to, can give us some indications of possible injury. We'll then go further and look at the hyperechoic triangle, which has been talked about in a few of the past chats, so I won't harp on it right now. But when we look at the hyperechoic triangle, we have the conjoint tendon. We'll see the semimembranosus, which will come off more laterally and then move medially in its tendon. The biceps femoris and the semitendinosus, which will be more superficial, and then the deep adductor magnus, which you can see over here. So when we look at the ultrasound, we'll get a good picture of that. Then we go on and look at the common fibular nerve, specifically in the areas we just talked about. So this is the entire common fibular nerve. It splits off from the sciatic nerve and comes out laterally. As it comes out laterally, it gives off that branch to the short head of the biceps femoris, and then continues down here, and it will split into 3 different nerves. You'll have the articular branch, which will come up and innervate the tibiofibular joint. You'll have the deep fibular nerve, which will come down on the anterior tibia and fibula, and then the superficial fibular nerve, which will come down the lateral aspect of the leg. So looking at the biceps femoris tendon, this is an area we need to look at because the biceps femoris tendon, either short head or long head, most often it is actually the long head, can attach a little bit more distally and can have a bit more tension. That can provide a stretch injury to the fibular nerve and cause a lot of irritation and pain, which can cause foot drop or other symptoms that we see. We'll also want to look at the fibular head. Now, this is a look from a MRI study where they looked at the split for the fibular head. There's variation of where the three nerves come out. So in 81% of individuals in this case, it was the split after the fibular head as we normally see it. In this instance, it was between the knee joint and the fibular neck. And then in 10%, it actually goes above the joint. And in those people, they're at very high risk. So really identifying the way in which the nerves are splitting is important to get a sense for what people might have as far as risk factors. Looking at the deep fibular nerve, so the deep fibular nerve is going to come down the center of the leg here, and it's going to extend down and give off the branch to the first dorsal interossei. And then down to the sensory to the first web and second web space, which will be right here. So we'll talk about that when we get to the scan, but that's that nerve, and it's innervating all the deep anterior muscles of the lower leg. This is a good look at the picture here, a good look at where the nerve comes out of the distal aspect here. So you can see the deep peroneal nerve, which is very close to the anterior tibial artery, and that'll follow all the way down from the fibular neck. So that's a great reference point, and we'll watch that when we see the scan later. Then we look at the superficial fibular nerve. So again, where we have our common fibular dividing, we'll see the lateral aspect will be the superficial fibular nerve. And this, it goes very superficial, and then will come out and even go right up to the skin, and it'll leave the fascia layer. Now that exit point is important because that'll help us, that can also provide risk factors. So we should find out exactly where it is, whether it's low or not, can be hurt with ankle sprains, specifically doing inversion sprain. We talk about the articular branch that innervates the tibiofibular joints. So the thing about this is when there's not a obvious injury, this is actually the most common location where you can have intraneural and extraneural ganglions form. So we want to get a good evaluation, and you can do that by placing the probe directly across this joint, and then taking a look at the articular branch, and then scanning it back to where it divides and comes back to become the common fibular nerve. And then lastly, the sural nerve. So we kind of touched on this before, but here's the common fibular nerve coming off of it. We have the lateral sural branch. In most people, you have a fibular communicating branch, which comes down the sural nerve, joining with the medial sural cutaneous nerve, which comes off of the tibial nerve. But in others, it can have different presentations. Sometimes there's no communicating branch, and this can just come down and provide sensation to the lateral leg. So it is important to understand and look at these splits and know what the anatomy of your patient is. Is the first starting point where I always look. I first try to find the tibial nerve located in the popliteal fossa, and then scan up and back and try to find where it splits off from the fibular nerve and joins together to become the sciatic nerve. So on the right-hand side, I'm showing you with this box, the scan, how I do it. So starting here with tibial, going up to sciatic, seeing fibular, coming back, and scanning back and forth. Now, I think it's worth mentioning that when I start these scans, instead of just going directly in and finding the structures that I'm looking for, I actually start out by doing 10 or 15 sweeps up and down the patient, and I'm looking at a few things. So first, I'm looking at the general look of the person's leg. So they have lots of atrophy. Am I seeing a lot of shadowing, or am I seeing a lot of bright signal that lets me know that it may be overall, a lot of injury to nerve going on? Secondarily, I'm looking at the nerves and how they're splitting, as we just spoke about. Then I'm looking at the specific nerve, and I'm looking to see, is there any focal thickening of the nerve or any area that looks abnormal compared to other areas where that nerve is? And lastly, I'm looking at the fascicular architecture. So as I'm looking at the specific circles within the nerve, I'm looking to see, is there one giant circle with a few small ones or lots of tiny ones? And how does that change as we scan up and down the nerve? And we'll talk about what's normal and abnormal as we go. So then I'm just going to report my ultrasound findings for each level here. So like I mentioned, the three things I'm really looking for are thickening, entrapment, and fascicular changes. So in the tibial nerve, visualized at the popliteal fossa, I didn't find any of those issues. So now let's take a look at the common fibular nerve at the biceps femoris. So I tried to label some of these pictures to give you a better sense. And obviously up here, I'm gonna have all the diagrams as well, so you can look at the basic anatomy. So here is the fibular nerve right here. We have our long head of the biceps femoris, our short head of the biceps femoris, and this is the lateral gastroc down here as well. Then on this one on the side, we have a long axis view. Important to get a long axis here as well. So here on the long axis, I'm looking for any notching, any areas of the nerve that may be compressed in comparison to others. And this looks nice and uniform across the nerve. So it looks normal to me. And you can even see in here, there's some fascicles of individual nerve fibers as well. So if you see specific prominent nerve fibers, you may be looking for that as well when you're scanning. So here's the movement of how I'm looking for this biceps femoris. We start by sliding down, and then I'll turn my probe into that long axis to get that same picture. So that's exactly what we're looking at there. Okay, so nerve scanning can be challenging to see when you're just looking at a one static picture. So for a lot of these, I have short videos that I'm going to show. So this is looking at the common fibular nerve. So let's take a look. So this is the common fibular nerve as it goes down across the head of the fibula. So I just want to point out one or two quick things. I'm just going to go back here. Okay, so here's our nerve right here. I'm going to slide forward, keep your eye on that. As we go forward, as the nerve is coming down, the nerve's right here. You can see when it gets to the head of the fibula here that it changes shape just a little bit, right about there. You can see that it changes shape and it's very close right there to the head of the fibula, which is right on this side. And then you want to watch it here as it goes past the head of the fibularis longus, the tendon of the fibularis longus, and dives into the fibular tunnel. So let's look at exactly how we're doing that scan right here. So just coming right down, getting over to that fibular head. So that's a movement of what we just did there. So then I'm going to measure the common fibular nerve because it helps us to know if it's thickened or not. Sometimes it's hard to tell without doing some measurements. So I generally measure proximal to the head of the fibula and then right at the head of the fibula. So these two measurements were identical at 9 millimeters, which tells me there's no thickening of the fibular nerve. You can also measure more distally. Sometimes I'll do a few measurements. So I've seen a few different pieces of literature regarding the size of the nerve at the fibular head. And the average was around 9 millimeters in terms of size. And then there was a difference of 1.27 millimeters between the symptomatic leg versus the asymptomatic leg. And as well, they looked at it in comparison to the popliteal fossa, and there was a 1.27 millimeter difference between that as well, which was significant. And greater than, there's been a few different people in the literature who put out different statistics, but it seems to be greater than 11.7 millimeters being enlarged. But really when I'm doing it, because there's so many different variations and variability, I'm looking for a 20 to 50% change in the size of the nerve from the proximal or distal aspect. But it's important when you're measuring the nerve to consider a few things. So you want these fascicles to be as circular as possible, especially around the fibular nerve, because you can see it, you're on an angle here. So you don't want to be measuring them obliquely where you may lose some of the, where you basically may be seeing the nerve representing to be larger than it actually is because you're looking at an oblique angle. As well, when the nerve is going distally from the popliteal fossa, it also contains a lateral cerulocutaneous nerve. So ideally you want to measure after that nerve splits off so that you're not measuring a falsely enlarged size of the nerve. So here's the path of just moving down and measuring that nerve as we just shown in the last diagram as well. So here is just a couple pictures of the long axis of the common fibular nerve that I wanted to share with you so that you can see how we do the long axis scanning, because it's a little bit challenging since it's going behind the fibular head. So that's turning the probe and getting it into the correct angle to where we're looking. This is the first picture, which will be the more proximal aspect where it's going over. This is actually the head of the fibula here, although you can't see it great in this picture. So I put up the highlighter here just to show you where that nerve is. Here's the next picture. So now the nerve is coming down this direction and diving this way. And then the last one, you can see as we go even further distal that the nerve is, now I put in a good toe into the transducer so it looks more parallel, but it's still kind of continuing on from that aspect there. And you can even see some of the nerve fibers within the nerve right around there. On any of these images, I did not see any specific notching nor any signs of thickening. So when I give my ultrasound findings, the same thing. Common fibular nerve at the level of the biceps femoris and fibular head did not show any signs of entrapment, focal thickening, or fascicular changes. I do want to make note that the nerve is in close proximity to the fibular head. So I put that in the report as well so that any clinician would know there's a possibility for some stretch injury, although we didn't see actual physiologic changes or signs of specific entrapment. So now looking at the lateral cerulocutaneous nerve, so I'll show you what we were just talking about as we watch the nerve split. So right here you have the common fibular nerve as it's moving forward. Right there you have two nerves, and we're going back a little bit and forward over this area. And you can see right here you have the common fibular nerve, and this is the lateral cerulocutaneous nerve. And then as we advance, they will separate, and there goes the lateral cerulocutaneous nerve right there. So this is a picture of that aspect of the image. And if we click that, you can see the fibular nerve and then the lateral cerulocutaneous nerve, the two different distinctions of the nerve. And here's just the cartoon picture once again, so you see what we're looking at. So when we're scanning the lateral cerulocutaneous nerve, as I mentioned, I'm going to scan down it. I'm going to look at the medial cerulocutaneous nerve and the sural nerve. If you have trouble finding it, you can always start at the tibial nerve, find the medial cerulocutaneous, and scan distally from that as well. So here's a quick image of me doing a scan on that. So ultrasound findings, lateral cerulocutaneous nerve was visualized splitting off the common fibular nerve, descended distally to join the medial cerulocutaneous nerve and form the sural nerve. No evidence of entrapment, focal thickening, or fascicular changes were seen. So now we get to that three-way split. This is a good place to take a picture and take a look because you'll see where the nerves are dividing and see if there's any injury or issues there. So I'll let this play here. Here's your common fibular nerve. We're scanning down. There's fibular head right there. As we continue distally, right there, let me just go back for a second. Right around here, you can see these big circles, they're starting to divide. So this goes into what I was talking about earlier, where there's different changes of the nerve fascicular architecture as it moves. So as you see here, when we're more distal, the nerve going right next to the bone actually turns from being a lot of small fascicles to being one larger fascicle. And my thought is that that's likely done to protect the nerve so that it has one stronger an anatomical point rather than having lots of small fascicles. So I'll go back to just show you that, highlight that point. So if you see the nerve as we're up here, you see lots of fascicles in here. You can see all these little circles within the nerve, right? And as we continue distally, still a bunch of fascicles here, and distal, 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 and now we see that split and getting into smaller, larger fascicles. So here's just a labeled deep fibular nerve, articular branch, and superficial fibular nerve in that picture. And just to show you the image of the scan, very basic, just go down and look at the split. Next, we'll look at the deep fibular nerve. So when I scan the deep fibular nerve, as we talked about before, we're going to use our anterior tibial artery, basically for our reference point. And remember, people with tight fitting shoes can have injuries distally, so we want to look down to the ankle. So let's show a picture of this. This is a little bit difficult to follow because it's a smaller nerve. So the nerve is right about here, and I'll move my cursor so it doesn't get caught up. Keep your eye on that nerve. I'll try to get back to it in just a minute or two. It's right over here. right next to that artery. And I'm just toggling as I'm going to keep it in the best view possible. It gets challenging to see because it's deep, but I'm just continuing to toggle, continue to try and keep it in the center of the screen and moving back and forth as I'm looking at this nerve. And now it's ascending as I'm going more proximally, and you'll see it coming up a little bit more clear in just a moment. Still keep your eyes in the center of the screen. Here it is, moving forward, coming up, coming up, coming up, coming up. And now it's going back to the split that we just looked at from the other side. And as it continues out, oops, I think I ended the, so as we continue up that split at the very end, it joins back right about there to back to making the common fibular nerve. So this is, again, this image of the basic nerve that we're looking at. There's where we can start with our transducer. Of course, we can go more distally if there's an injury more distally that we're suspecting. And we just scan straight up the nerve. So ultrasound findings, the deep fibular nerve was visualized distally in the anterior ankle next to the dorsalis pedis artery and scanned proximally in the anterior compartment to the common fibular nerve. No evidence of entrapment, focal thickening, or fascicular changes were seen. Now we'll look at the superficial fibular nerve. So we're going to show another video, but basically for the superficial, I'm going to start at that point where they divide, and I'm going to follow it down to the point where it exits out of that fascia, specifically where it's common to have an entrapment. So go ahead and take a look at this one. So here's the nerve right here after it just divided. And it's moving up, moving up. I'll zoom in just a second and you'll get to see it much better. It's going right in that fascial plane between those two muscles. And there we're zooming in. We'll zoom in even a little bit more as we go distal, distal, distal. You can see the nerve really clearly there in the center of the screen. It's right here. And just keep your eye on that nerve as we go even more distal. It's now getting to the fascia, and right about there, it just exited out of the fascia. So that's an area for entrapment or injury, especially with ankle sprains or repetitive inversion, eversion type injuries where the nerve can get stretched and pulled and get taut in that fascia. As well, people who have compartment syndrome can get injury from the surgery and or stitches, scar tissue, et cetera, that is in that lateral compartment can impinge on the nerve there. So this is the scan. You see the transducer there, and we just move distally right along the nerve. Obviously, once again, you can continue distally out and see the smaller nerves as far as you want to go. If there's a more isolated injury, that's distal. So as far as the superficial fibular nerve ultrasound findings, it was visualized in the lateral compartment, tracked distally to where the nerve exits the fascia. No evidence, again, of entrapment, focal thickening, or fascicular changes were seen. Now we have the articular branch in the tibiofibular joint. And here we can place the transducer along the tibia and the fibular head and look in the joint. So here we have some neurovascular, and the nerve is sitting right here, actually. Don't see any signs of injury into the joint, which is something we always look for. So we'll follow this quick video and watch the nerve here as it follows right along. It's right there. Keep your eye on that. You move proximal and watch it go back. It's going to join back up with the other nerves and come back over here to eventually go back to the common fibular nerve as well. And there it is. And then we can see the scan as we just go out to from the joint back to where it splits. So ultrasound findings, the articular branch of the fibular nerve was visualized in the tibiofibular joint and tracked proximally to where it splits from the common fibular nerve. No evidence of entrapment, thickening, or fascicular changes. So now we get to the sciatic nerve. We're going to now move more proximally on the patient. We're going to go up from that split where we found the fibular and tibial nerve, and I'm going to just scan all the way up the sciatic nerve, going all the way up to the greater sciatic foramen. But one key area to look at, and obviously as I'm doing this, I'm looking at all the hamstrings, looking at that biceps, femoris, short head, long head, And as we're doing this, one challenging part can be when you're scanning the sciatic nerve, there's certain areas where you may lose it or it may get deep. So one suggestion and thing that's helped me is turning longitudinally on it, so you can get into a long axis, flip back and forth between long and short axis, and just scan it up in long axis, and that can help you identify it in those areas. As well, sometimes you get shading from the saphenous vein or other veins, and you can occlude those veins distally, and it decreases the shadowing that you have on your picture. So let's go through this scan here quickly. So here's our sciatic nerve right here, just following that up as we're looking at it, directly going through that hyperechoic triangle right there. And you can see the hamstring muscles surrounding it as well. And here we're starting to get some of that shadowing you can see, probably from this superficial blood vessel that was right there, which could have been occluded. And that's that. And then here's our picture, and I'll just throw on our labels. So we have our biceps femoris, our semitendinosus, conjoint tendon, which is comprised of semitendinosus and biceps femoris, our sciatic nerve, and then our semimembranosus, which will be located medially. And deep to all of that, we have the adductor magnus, as we saw in this image. Here we are starting down by that conjunction, or that junction of the tibial and fibular nerve, and then we'll just scan it proximally all the way up. So let's continue with the scan. So next we're going to look at the piriformis. So here we have the gluteus maximus, here's the sciatic nerve, and here we have the piriformis. Same thing, this is a long axis. Here is the gluteus maximus, here is the sciatic nerve, and here's the piriformis. Now in these pictures, we're starting to find some pathology. So this nerve quite looks a bit swollen, and actually I believe that this side here looks more to be the fibular aspect of it. Here you can see almost a division, and this part appears to be the tibial nerve. And then when you look in long axis, you can see that it goes from about a more narrow point to quite a wider area where it's ballooning out. This tissue also does not appear to have the same type of fascicular architecture. I maybe see a few fascicles, one maybe there, but ultimately it does not look like nervous tissue. So that's what we note there. And then here up here is the scan where we have it on the piriformis. There's fibular nerve and tibial nerve identified. And then we'll move on to the greater sciatic foramen. So here is a video, and we can watch as that sciatic nerve is disappearing into the greater sciatic foramen. So there's the nerve there, and there it goes disappearing down. I'll play that one more time. Just kind of go through a little bit slow. So as we're moving forward, there is the sciatic nerve. There's the piriformis below, and as we go more proximally, you can see it right there, dives down underneath. And we see some hypoechoic signal actually behind it and around the nerve as well. Here's gluteus maximus, and the piriformis was down below. And here's our anatomical picture, and just sliding up, very basic. So because we found this pathology, we want to measure it and get a sense of what we're looking at. So first we did some height and width. So we found 0.75 centimeters in height, 1.3 centimeters in width, and then we looked at the length, and we had about a little more than 5 centimeter length. So how do we write this? The sciatic nerve at the greater sciatic notch and piriformis revealed a thickening with abnormal fascicular architecture. There's abnormal tissue measuring 0.75 centimeters by 1.3 centimeters by 5 centimeters. The proximal extent of this thickening cannot be seen beyond the greater sciatic foramen. So we're not sure if this is the entire tumor or if it continues more proximally. After around 5 centimeters going distally, it returns to normal appearance. Scanning distally from the hyperechoic triangle down to the split into the tibial and common fibular nerve above the popliteal fossa, there was no signs of focal thickening or disturbances of the fascicles seen in that aspect of the scan. So putting it all together, our full report here. So the study we did was a complete musculoskeletal ultrasound of the fibular nerve. We did the left side. Of course, we could compare to the right as well. We didn't show any of those pictures here, just to show you the left side specifically. The indication is decreased sensation in the left anterolateral leg as well as foot drop, as we saw in our patient. History, 59-year-old patient with insidious left foot drop. The equipment we used was a GE Logic S8 with an 8 to 18 megahertz hockey stick and the 3 to 12 megahertz linear transducers, and all structures were evaluated in longitudinal and transverse planes as applicable. Generally, when I'm doing the scan, I'll be starting in that transverse plane, and anything that looks abnormal will always be going into the longitudinal plane. And as well, any areas where there's common pathology, I'll look both in longitudinal and transverse, as we did in this scan. So this is the long report. So added in all of those reports that we found just before, and then I'll give the impression since we already went through all the other findings. Abnormal ultrasound examination of the left sciatic nerve at the level of the greater sciatic foramen with a mass measuring 0.75 centimeters by 1.3 centimeters by 5 centimeters. The proximal aspect of this mass that extends beyond the greater sciatic foramen was not able to be examined due to limited visibility on our ultrasound examination. Of note, the common fibular nerve is also in close proximity to the fibular head and may be undergoing mild compression due to stretch. So we may have a double crush injury in this situation where the fibular nerve is actually getting compressed as well. And I thought this was an interesting case to present because if you had just went to your scan, didn't look up at the sciatic nerve, you would have looked at that fibular head and you could have said, well, you know, it looks like this might be the abnormality. It's getting pretty close over here. Maybe we have a stretch injury. You know, I don't see any specific entrapment or thickening, but this looks like the problem. Reported that back to your neurosurgeon who may have gone in and done a surgery when we missed what looks to be a mass or a tumor at the proximal aspect of the sciatic nerve that we did find an ultrasound, and for 3 months, this patient didn't have a diagnosis. So that is the case, and these are the references. Hopefully I'll be on to answer any questions and hope you guys enjoyed the presentation. Thank you so much for having me. It's been a true pleasure to do this presentation.
So let me see. I don't know if Scott is on or not, but that was.
I'm here.
Hey, Scott, great job. You know, very comprehensive. That's a long scan there, right? Going from pelvis to foot there. You know, a couple things, and your images were great. A couple points, you know, from me. You know, when we're doing these scans, you know, we want to try our best to maintain a protocolized, you know, examination that fulfills criteria for a complete ultrasound evaluation. You know, from a billing perspective and just for a, you know, completeness perspective. And, you know, typically for a complete examination, you know, we need to include, you know, nerves, which you obviously did, muscle, a joint evaluation, you know, some sort of tendinous structure, and then a periarticular ligament as well to fulfill, you know, the true requirements for a complete examination. But this is an interesting case, you know, and I think it kind of points to the importance of using, you know, the patient and their history and their examination, right? Because I think, you know, your initial history of his injections or whatever, they were pretty high up, you know, probably clues you into a more proximal injury. And, you know, who knows, is this common fibular nerve compression at the knee a red herring? You know, tough to say, but kudos to you guys for, you know, thinking and using your history and physical exam to help with this patient. You know, with the common fibular nerve, like you mentioned, there are multiple entrapment sites kind of throughout the course of the nerve, and throughout the course of the distal branches, and even proximal, like you mentioned. History, like I said before, can help, you know, guide you and help localize your ultrasound examination. I think, you know, with compression, you know, at the lateral knee, I think it's really important to describe, you know, truly where the nerve is getting compressed. I think a lot of times we throw that word around, you know, fibular tunnel, and what does that mean? You know, technically it's that tunnel that's formed as the nerve dives underneath that kind of myoaponeurotic arch, with the peroneus or fibularis longus, and there's a component of the soleus there. You know, I think that's the true definition of the fibular tunnel. But, you know, certainly, like you mentioned, you know, as the nerve courses through, as the deep fibular nerve comes out of the distal tunnel, you know, those are all different compression sites. So, you know, describing exactly where that nerve is getting compressed. You also mentioned, you know, potential compression from the biceps femoris, not only the tendon, but there can be some muscular anomalies that can compress the nerve. So I really think, describing that, like you mentioned, describing where it's being compressed is really helpful, especially if this is somebody who you're going to send over to a surgical colleague for, for consideration of a surgical procedure, like you alluded to. This patient's compression was fairly probably as proximal as you can get, at least in our world. And so, describing where the compression is important. I've had a couple patients, sent to me for a second opinion after a, fibular nerve compression or decompression at the fibular head, and they have persistent symptoms. And, you look with ultrasound and their compression is, maybe 5 to 6 centimeters proximal from whatever structure that's compressing it. So comprehensive description and accurate description, I think, is really important here. Yeah, I think those are the main comments that I had here. Does anybody else have any comments or questions for Scott? All right. Well, hearing, I don't know if somebody just tried to say something, but regardless, so hearing no questions, we will call it here. Thanks again, Scott. I hope Europe is treating you well. Thanks for hopping on and joining.
Thank you so much for having me. Appreciate it.
Yep, absolutely. All right. Well, happy Friday again, everybody. We'll be back in 2 weeks with Kira Novakovsky, who is our fellow, talking about one of our fellows talking about a distal IT band bursopathy case. So some more lateral knee stuff. But everybody have a good weekend. Stay warm and see you in a bit.
It looks like there was a question in the chat.
Let's see. Thanks, Tracy. Side nerve is seen above piriformis rather than beneath. This is unusual. Do you think it was injured by the? Yeah, thanks, John. Scott, you want to tackle that? It's a good question.
Yeah, it's possible, but looking at the mass looking at that 3 months later, that may have been the thing that spawned it off. You may have gotten an injection that was in close proximity to it, but the tissue to us did not look like it was, fluid from an injection or injury from anything acute. It looked more to be, abnormal tissue that we saw there. And that's why we then sent over to get biopsy and get that MRI that we were looking for earlier. So yeah, good question.
I guess that stems one more question, Scott. So do you think these injections that he was getting up in his buttock area, you think that part of the story is just a red herring here, not related?
I think, I think that likely the injections didn't cause what he had as far as any injury, but I think it may have been something that kind of spawned on the symptoms and made him become a little bit aware of it more quickly. However, like the story of recovering and then 3 weeks later, noticing something while sitting on a hard, library table or library chair, that could have been the thing that spawned it off too. So hard to say, to be honest, but it doesn't seem to be the factor in my mind.
Sure. All right. Thanks for answering that. John, thanks for the question. Tracy, thanks for bringing that to my attention. All right. Now I see no more questions and I see nobody unmuted. So now have a good weekend and see everybody in a couple weeks.
Great job, Scott. Thanks, everyone.